all over the world. Just to give you a flavor of the numbers that we're dealing with, heart failure affects 26 million people worldwide. Heart failure is the single leading cause of all hospitalizations in US and in Europe, accounting for 1 to 2% of all hospitalizations. And more than 670,000 cases of newly diagnosed cases of heart failure occur annually in the US alone. And this is data from a couple of years back, and this is only on the rise. But let's not veer off to the international data. Let's see what's happening in the kingdom here. So I'm just going to quote the Hearts Registry, which looked at heart failure in the kingdom, and compare that to the international registries all over the world, which were kind of in the North America and Europe, which are relatively similar numbers, sorry. So if we look at our patients are presenting about a decade younger than the international registries, and they come in with a bigger bag of problems. They're more diabetic, they're more hypertensive, and they have a higher ischemic heart disease burden. So we're not only dealing with a younger population, but also with a sicker population and more comorbidities. So is that enough to justify opening a heart failure clinic? Well, I think when you are opening up any new service or establishing a new service, you need to ask yourself 3 questions. Why am I opening this clinic? Is it going to improve the services? Who should be running that clinic? And how should that clinic be run? So let's start off with the why. The questions that we need to ask to assess the why are as follows. Very importantly, is this new service going to improve mortality and quality of life? Are we doing a good job anyways? Do we need to improve upon the workflow process that we have with dealing with heart failure patients? And can we reduce hospitalizations by opening up a heart failure clinic? And finally, especially in the current economic era, is it cost effective? That's always going to come into play. So let me start off by answering one of these 4 questions. Are there gaps in the treatments that we can improve upon? So this is a relatively old paper now published about a decade ago, looking at the pharmacological therapy in heart failure. We know that it's equally important to start the patients on ACE inhibitor, beta blocker, and melanocortin receptor antagonists, but it's just as important to up-titrate these medications to the maximum tolerated doses. So dose does matter. So if we look at these patients, again, this is pre-emphasis HF. They didn't look at the aldosterone or melanocortin receptor antagonists because it was only used in class 3 and class 4 heart failure. But if we look at ACE inhibitors and beta blockers, it was shocking to find out less than half of these patients were kept on the optimal target dose, and close to only 10% of the patients were on a target dose of a beta blocker. And we know that dose does matter and dose will improve heart failure. So the answer of this question to me is quite easy. Yes, a heart failure clinic will give you room to improve treatment of heart failure patients. The next question, I think the 2 questions, I lumped them together. Can we reduce hospitalization, and is it cost effective? If you reduce hospitalizations, we know ambulatory care services are cheaper than inpatient services. So if you reduce hospitalizations, then effectively you're reducing the cost on the hospital itself and on the Ministry of Health. This is, again, a really old paper, but I think it's still valid. Once they established a heart failure unit, they looked at the total number of admissions the year before and the total number of admissions after they established that service, and undeniably half of the total number of admissions were reduced by just this simple intervention. So again, the answer is yes and yes. It is reducing hospitalizations and it is cost effective. Now, what about improving mortality? A more difficult question, but let me give you this graph that's always presented in talks looking at the organ system failure trajectory. As we know, you always start off with a certain baseline function, and every time you get admitted, your functional status significantly reduces and your mortality risk reduces as well, increases significantly as well. But even if you manage to go back to being discharged, you're never back to your baseline. You're going down that slippery slope until death. So if we reduce admissions, then we hopefully be able to plateau the patients to a certain functional status, thereby improving mortality. And this is an extrapolation, but it's a very difficult question to answer. So again, in my point of view, heart failure clinic does improve mortality. So what happens when you don't have a heart failure clinic? What happens is these patients get blended into the regular case mix of general cardiology clinics. So up titration, as was noted earlier on, is slow, it's suboptimal, and you have less time with your patients. Maximum time you get is 15 minutes for follow-up patients in a general cardiology clinic, which means you don't have enough time to optimize the medications. You can't have enough time to address other comorbidities which are important, such as iron deficiency, anemia, diabetes, and so on and so forth. And you have less time to actually educate the patient, which is a very important part in the whole heart failure process. And the next clinic, when you tell them come back to the follow-up, it's going to be 3 to 6 months at best, which means that they don't have quick access if they have any early congestion signs, and they end up in the ER. So going, hopefully, again, hopefully I'm talking to the converted. We know about the why. There is enough rationale to establish a heart failure clinic. The next question is the who. Who should run the heart failure clinic? I think there are two very important personnel to run the heart failure clinic, the heart failure nurse, along with a heart failure and transplant specialist. But again, we like a multidisciplinary team approach. So you can, if you have the manpower or the expertise, you can always have a cardiac nutritionist, a clinical pharmacologist. Cardiac rehabilitation is an absolute must in my book anyways, physiotherapy, social worker, occupational therapy. And again, as Dr. Matteo earlier on mentioned, these patients eventually want CRTs, they might go for mechanical circulatory support, for ventricular assist devices, and so on and so forth. It's very important that you have a go-to person and a cardiac surgeon for assist devices and a cardiac rhythm management specialist as well, along with an echocardiographer, so you all talk about the same patient and you're all kind of talking within the same field. Going from the who to the how can we establish a heart failure unit? Now that's, I think, the most tricky part. Prior to establishing it, you should have very clear eligibility criteria. I think checklists are the secret. They're the key to success, to a successful heart failure clinic. Examples are discharge checklists. I'll talk very briefly about telemonitoring, a one-stop initial assessment, algorithm and pathways for up-titration therapy, and supplementing the patients with clear and useful education material. So starting off with eligibility criteria, again, you have to ask yourself a question. What population of patients would receive the most benefit in your institution out of a service as this? So let me just tell you about my institution. We have a huge oncology service. It's covering the whole eastern province and even taking patients from the central and the western provinces as well. In that case, chemo-induced cardiomyopathy is one of any patient, even if they have mild LV systolic dysfunction, they get fast-tracked to the heart failure clinic because it's a much-needed service. And we, again, because it's an overwhelming number of heart failure patients with very little manpower and resources, you can only stretch yourself so much. So we only take in the moderately reduced LV systolic functions with at least 2 admissions with acute decompensated heart failure over the past 12 months. So that's proof to us that the general cardiology heart failure clinic is not enough for these sorts of patients. But we, again, because it's it's only a couple of people that are involved in this service, we're not taking in, let's say, bedridden patients or hemodialysis patients. So you should have a clear idea of who is eligible for that service. Again, as I mentioned, I think the secret is always in the checklists. Checklists have been shown to minimize errors in the airline industry. They've also been shown to minimize errors in the healthcare industry. So again, you can access these checklists online. They're all available. We always start off with a discharge checklist upon the patient's discharge from the hospital, if they're eligible for heart failure, to make sure they're on adequate therapies and they've received adequate intervention, education, and so on and so forth. It's simple. It's a yes or no. It can be done by a nurse or by a resident. And once the patient is discharged, again, there's an issue about calling the patients 5 to 7 days after discharge. Telemonitoring has been looked at time and time again, and the last of these literature reviews was, or the studies looking at it, was the BEAT-HF trial, which was published in the which was presented in the American Heart Association and published earlier on this year. And unfortunately, as we stand today, the telemonitoring is not there yet. It hasn't been shown to be more, significantly more effective over and above what we offer in a heart failure clinic, but I still believe that it is useful in a select group of patients. So I'm sure if you do studies, there is a select group of patients or certain centers or certain cultures that may benefit from telemonitoring. It's very important once the patient arrives to the clinic, their first initial assessment, that it's sort of a one-stop shop. You have to have an extremely thorough history and examination extracted from the patient. That's your first visit. And make sure that all of the workup is done, ECG, echocardiogram. You talk to as Dr. Matteo said, talk to your echocardiographer, make sure everybody's on the same page, organize for any other specialized workup if necessary, make sure that all of the blood work is done, including things like, that might be overlooked in a general cardiology clinic, such as an iron profile. Even though if the patient is not anemic, repleting those iron stores will improve their symptoms. Look at thyroid functions, ferritin, and so on and so forth. So initial assessment is extremely important. You need to look for reversible cause, ensure all aspects of patient care are addressed. It's quite important, again, depending on where you work, you have to be quite friendly with your internist and your diabetologist, your home health care system if you have one, and your palliative services as well. You're going to need them. And rather than begging for them, you want them to be on board with you looking after the patient. The most important part of the first assessment is to set targets. You need to be reasonable, and you need to sit with your patient and see what was their baseline and how do they feel today, and set a target. I'm not going to get you to run a marathon, but I'll try to get you back to where you were and maybe a bit better. So it's very important to set reasonable targets and go up and above from that. So I think that's key as well to success. Algorithms and pathway for up-titration of therapy, again, so that we've noticed that these patients are started on the right medications, but the therapies are not up-titrated adequately. So it's very important to know what medications work, what are the side effects that you should be watching out for. Up-titration in the initial phase should be, bring the patients back every 2 weeks to 4 weeks at most, be guided by symptoms and renal function. Don't worry about, a lower blood pressure, go up on the ACE inhibitors, and aim to reach your target doses or stop if they can't tolerate any further. Again, as we mentioned, dose does matter. It's not enough to start the ACE inhibitor, beta blocker, and melanocorticoid receptor antagonist, but rather go up on the doses to the maximum tolerated doses. Once you've established that foundation, and I've added ARNI onto that because I believe that's, again, one medication that will replace your ACE inhibitor or ARB, then you work on top of that for devices, assist devices, and transplant. And again, you need to be talking very closely to your EP specialist and your cardiac surgeon as well. Going from that to the patient has to be empowered. He has to understand his disease process, and he needs to be supplemented with the right educational material. I think this is one example of where collaboration worked best. The heartfailuematters.org is